So we can send out the recording to any attendees who weren't able to join us live today. And then you'll also have it to look back on in the future to reference to, along with our resource list. So forget my note about being able to use your camera, but still feel free to use the chat or the Q&A feature to ask any questions. And like I said, as people enter the room, I'm trying to give everyone the ability to be able to unmute themselves and ask questions as you feel like you'd able to, but please keep yourself muted if you're not talking at the time, so we don't distract any other participants. Next slide, please, Kristen. So before we get going, let's do something fun as a welcome. If people want to pop in the chat where you're coming from. I know almost everyone is from Michigan here today. I happen to be physically located in Minnesota, and feel free to share whether you prefer to hang on to the summer weather or if you're ready for fall. For me, I can say I do not want pumpkin spice anything. I about cried when I saw pumpkins at the grocery store, and I'd like to hang on to this summer weather as much as possible, despite the fact that it's 105 degrees in Minnesota. So,
hey, Claire, it says the chat's disabled.
Why would it say that? Well, we'll have to work on that. It was disabled or enabled to start with. So if anyone wants to jump in and just say, so DJ, I'm going to put you on the spot then, and then you have to answer.
Uh-oh. Yeah, I'm looking forward to some fall weather. I know every day is not like this where it's 1,000 degrees kind of thing, but yeah, school coming back here pretty soon. I guess just going with the flow, and yeah, ready for fall to start.
Denise,
and I'm pretty indifferent to pumpkin spice flavored things, I guess.
Denise, I'm going to pick on you then. Are you summer or fall?
Oh, bring on the pumpkin spice and the shorts with a sweatshirt.
All right. Any other brave souls out there?
Summer all the way.
All right. Thanks, Luann.
Same here, summer all the way.
Yep.
No pumpkin spice, nothing for me.
I'm fall. I love fall's my favorite season.
Oh,
So too. Yeah, can't beat it.
I just hate what comes after it.
Bring on fall leaves. I love the color.
Well,
I'll take the fall weather, just cancel winter.
Yeah, exactly. I can get behind that. Well, thank you, everyone. And Kristen, you can go to the next slide. We moving? Oh, thank you. I was going to say, we're going to do our poll here. So before we get started, I just want to get a little insight from everybody. From your perspective, and there's some NA answers, or you can put neutral for those questions if you're not from a dialysis facility, but just want to get some understanding of your perspective of the facilities. So the first question is, at our dialysis facility, we routinely audit infection prevention procedures and act on those results. Yes, no, or NA. Infection prevention education is incorporated into routine and ongoing staff education. Yes, no, or NA. So not just onboarding, but ongoing staff education. Infection impacts patient outcomes at our dialysis facility. Strongly agree all the way down to strongly disagree. The next one, our dialysis facility has areas for improvement in infection prevention. Again, strongly agree down to strongly disagree. And then the fifth question, I understand the purpose and process of an ICAR or IPRAT visit. There's a couple different terms that are used there, and it's okay if the answer is no, because we hope that you come away with that information today. So we'll give it a few more seconds so you have time to think and go through all the questions. And thank you everyone for responding. We'll give it about 5 more seconds here. Okay. So I see that most people are utilizing, or 8 out of 8 who answer from the dialysis facilities, that people are utilizing audits and acting on them. That infection prevention education is incorporated into education for staff. Both strongly agrees, and a disagree that infection is impacting patient outcomes at dialysis. Wow, lots of agrees that there's some areas of opportunity for improvement in infection prevention. That's great. And then 50-50 of whether or not we know what an ICAR IPRAT visit is. And we're going to learn more about that today towards the second half of the presentation. So thank you everyone for providing that. So we're going to go into the network part of it now. So here at the network, we are a quality improvement organization, and we are under contract with the Centers for Medicare and Medicaid. And as part of that contract, we are contracted to work with dialysis facilities and other stakeholders in our service area to meet several goals throughout the year. And many of those goals are really directly related or impacted by infection prevention. So for example, we know that infections contribute to hospitalization utilization, and we are tasked each year with reducing hospital admissions, readmissions, and emergency department visits. We also have several metrics on increasing vaccinations, specifically in the areas of COVID, influenza, and pneumococcal. And then we also have goals related to decreasing CVC infections and peritonitis rates in vulnerable populations, or those dialysis patients who are residing and receiving dialysis care in the nursing home. And while these goals are really clearly directly related to infection prevention, I like to think of like the far-reaching impact that infection has on other goals. So for example, we want to increase the number of patients on the transplant wait list and those actually receiving a kidney transplant. And of course, sepsis, we know, can impact transplant readiness and may result in a patient becoming temporarily inactive. So really the impacts on patients and goals are far-reaching. So let's go to the next slide. So why is this all important? Why are these goals and metrics important? And it's not about chasing a number. I can't stress this enough. It's not checking a box and saying, there, good, we're done, we did it, move on. Data are reflective of patients, of the people that we serve. And so I want us to hold that in mind as we move through the rest of the presentation today, that the patients are our why, and that improvement in data is reflective of improved outcomes in patients. And this is really particularly true with infection. And we see how it relates to network goals, but let's even take it a step further. So next slide, please. So to start with, we know that dialysis patients already are at an increased risk of infection due to frequent close proximity to not just staff in the healthcare facility, but access to other patients, frequent access to their bloodstream, weakened immune systems as a result of different medications that they're on, and kidney disease itself, as well as, again, regularly accessing a healthcare facility. And in fact, according to the CDC and the Sepsis Alliance, 7 out of 10 patients with sepsis have been shown to recently use health services or been in a healthcare setting or receive frequent care due to a chronic diagnosis. So obviously those are our dialysis patients with kidney failure. I mean, perfectly summed up right there. And sepsis, as we know, is not just attributable to healthcare infections. It can be due to wound, pneumonia, UTI, and so on. So as healthcare providers in the outpatient dialysis setting, we have an opportunity to carefully monitor for emerging signs and symptoms of infection. Because when infection progresses to sepsis, sepsis is the #1 cost of hospitalization, and it is costly. As the leading cause of readmission, not just in the United States, but in our network as well. In the nation, sepsis totals $3.5 billion each year due to those readmissions. And of course, more importantly than the financial impact, again, to bring it back to the human impact, that you can see at least 350,000 adults who develop sepsis actually pass away during their hospitalization or are discharged to hospice care. And of those patients who survive sepsis, many are left with long-term complications and kind of lingering effects over the rest of their life as a result of that infection. Next slide, please, Kristen. So this graph reflects inpatient admissions in dialysis patients in Midwest Kidney Network, so the Dakotas, Minnesota, Wisconsin, and Michigan, over our last contract year. So that's May of 2022 through April of 2023, this past spring. And you can see that that green line that goes horizontal there, that's the upper limit of our goal. So to reduce hospitalizations, we want those blue bars actually below that goal. And you can see that in that last month, we unfortunately did slip up above that, and we did not meet our goal of helping dialysis facilities reduce hospitalizations in dialysis patients. And so, Kristen, if you click next, you can see now the impact that sepsis had on those hospitalizations. That yellow bar is the rate of sepsis inpatient hospitalizations. It made up the largest percentage of our inpatient admissions at about 24%. And this year, just 3 months into the contract year, it's already contributing to 27% of hospitalizations. And now that's just, I should point out, when sepsis is used as the primary ICD-10 code on the Medicare claim, and that actually if I were to add in bloodstream infections due to CVC or peritonitis, this yellow bar would be even higher. So that brings me to my next point. Next slide, please, Kristen. When we track hospitalizations at the network, it's not all-cause hospitalization. It's just from a defined list of ICD-10 codes that we get from Medicare each year. And that list we keep on our website, and I'm going to share all the links with all of our attendees today when we're done here. But that being said, the sepsis codes are all-cause. They're not dialysis specific. And the reason being is that the dialysis patient has 3 touch points, typically with a healthcare facility every single week. And so there is an opportunity to address any emerging signs of, respiratory wound, UTI, infection symptoms, and hopefully have an early screening and an early referral process before that infection were to get to sepsis. And I can understand how that, from your perspective, by myself being by background a dialysis nurse, that doesn't really feel, dare I say, fair in our control. So it makes it even more important that we focus on what is in our environment and what we have capability of controlling. And that is reducing infection chances within our unit related to the patient and staff infection prevention practices. Next slide, please, Kristen. So how do we do that? Well, there's an opportunity to return back to the basics, and I want to kind of reframe it and calling it maybe not so much basics, but like a fresh perspective on it. And I've heard from various avenues, from Department of Health to staff in the facilities, just in a multiple ways, that there's a lot of post-pandemic fatigue. And that there might be some areas that have become more lax, and even if not lax intentionally, but just maybe confusion about what was COVID protocol, what should our current protocol be. So it's kind of like, let's all get on board again. So I have resources to address each of these areas, and starting with patient and staff education, I'm going to go through this more coming up on the next slides, but looking at what kind of new resources and education can we use for not just patients, but also staff on hand hygiene, procedural infection prevention, respiratory hygiene, screening and appropriate referral for any emerging signs of sepsis. Also, the use of routine audits. We'll go through some best practices and some tools for that. One thing I'll hit on a little bit more right now is the importance of data tracking and trending. So any solid improvement effort requires sound quality improvement processes, a data-driven approach. So we first have to start with knowing the numbers. How are you tracking and trending number and causes of infections or hospitalizations at your facility? Do you have a log? Is it up to date? And then what do you do with that data? Do you do the next step then of looking at a root cause analysis, starting a PDSA cycle to develop and implement some of these impactful interventions we'll talk about to improve outcomes and, pivot your approach as needed if it's not successful? And I don't want to go down the rabbit hole further on this QI approach. I know that we're kind of breezing over that, but what I do want to point out is that if any of these QI terms or principles that I just briefly overviewed aren't comfortable to you or you're not familiar with them, please reach out to us at the network and we're happy to provide resources and kind of walk through that QI process with you. And then finally, we're going to talk about a team approach and a culture of safety. Next slide, please, Kristen. So for each of these areas, and I know the screen looks a little bit goofy, I have a screenshot of our sepsis resource toolkit of all these different resources I have to address each of the previously discussed areas. The patient and staff education, audits, identifying sepsis early, and so on. And so this is a link on our website. I'm going to highlight the staff education. This ASN, or the American Society of Nephrology, self-paced learning modules. Now, I have a group of facilities that I had worked with last year who utilize these education modules with their staff and had outcomes as far as reduced sepsis hospitalizations. But they said aside from that, that data improvement, they also reported enhanced staff engagement and the whole team really buying in and learning more about how they have a role in infection prevention. The ASN also has some with free CEUs, but I encourage you to look at, staff education modules and think about how can we do this creatively? Can I assign some to staff to complete? And then the facilities I referenced that worked on it last year, for example, then they would pick a topic to kind of dive into further as a team and discuss it in team huddles at a staff meeting. And when people say, well, gosh, due to staffing challenges, I don't have time always for my huddles or my team meetings, looking at other avenues to creatively have discussions then on the topic. Can you utilize like a virtual messaging platform or your emails where you can start a post and say, okay, team, we learned about this week. What are areas you have identified in the unit where we're doing this well, or where could we improve? So just looking at some creative approaches there. Also in this toolkit, I have patient education included. The ESRD NCC has a wealth of patient education. If you haven't checked it out already, highly recommend it. A lot of their educational handouts are available not just in English and in Spanish, some of them are in other languages as well. And they're starting to even add in audio clips. So for our visually impaired patients, you can click on the link and it will read the education to them. And then again, think about how are we delivering that education to our patients, not just handing them, but, empowering the PCTs to kind of talk through some of those points as they're hooking them up. What did you think about, this information on washing your hands when you come into the unit and when you leave the unit? And then maybe making a patient bulletin board in your lobby that correlates with the handouts you've provided that week. And again, there's other tools and CDC resources that I have within that toolkit, and I will send that link to everybody who's here today. The other thing I will mention too about patient education as a different approach is looking at, do you have that champion in your unit who could be like a peer mentor or an infection control advocate and help talk to their peers, their other patients, about the importance of whatever message that your unit chooses as an infection prevention topic. Next slide, please, Kristen. So audits, we all know what they are and that we have to complete them. And I know sometimes I can relate to this. It quite literally feels like one more box that we have to check, but really trying to kind of change our thinking and think about how can we really truly utilize this as a tool to push us a little bit further. So we know that it's not just hand hygiene in general, but procedural with patients going on and off the machines, also environmental, how are things being disinfected if it's not single use and we're taking it away from the station. But going beyond that, looking at who's doing the auditing. Does the whole team know they're being audited? I would really encourage, having everyone have a role in auditing and changing it up. And the goal is not to be like sneaky and catch people. It's not, I don't want it to be like a punitive thing, but it's rather learning what are the actual practices that are going on? What are the routine infection prevention behaviors of staff when they don't think they're being watched? Because that's, of course, the majority of the time that they're providing care to the patient. patients. This will really allow you to identify and work through maybe any bad habits or shortcuts that have developed over time, or where there's just maybe a lack of knowledge and there's an opportunity, to do some re-education. I have a snippet here too of course, the core interventions in dialysis to prevent bloodstream infections. This is a proven method that when these are implemented, BSIs decrease, and auditing, or they call them observations, is part of that. All these tools are found at the CDC dialysis website, and that's part of the toolkit too that you'll be getting after today. And so next slide, I just have one more thing I need to quick wrap up before I turn it over to our Michigan team. Talking about team engagement, how to keep our team engaged and involved. So this is another tool from the CDC, a days since last infection poster. This is one I have personally used when I was still working in the unit. And there's no way for teams working together on quality improvement to make progress without everybody knowing what are our current rates and where are we trying to go, and really being all on the same page to get the ship sailing that direction. Really promoting to your team that it's not just your job as a manager, and it's not the QI team's job. It's everyone, from biomed to the AA, the physician, interdisciplinary team, everyone, the patients have an impact on this rate. It's just hard to find buy-in, established buy-in, unless, again, people know what the rates are and where we're going. And I'll just bring it back to the why, that when you're trying to keep your team engaged, emphasizing that data are reflective of people, of our patients, of why we're here. So we're not chasing a number to chase a number. We're doing it to improve outcomes for our patients. Next slide. So I breezed through a ton of information really fast. I want to leave Michigan some time to talk. And so this is my contact information. I'm happy to do individual deep dives of your own data at your unit, look at how we can get creative with specific interventions, depending on what you see are your biggest barriers. And I encourage you to all go back and look at the barriers in your facility. And next slide, I think then we're going to turn it over to the Michigan team, to Chelsea and Denise from the Michigan Department of Health and Human Services. And Kristen, we can stop sharing and we'll let them pop up their slides. In the meantime, unfortunately, the chat was disabled and it won't let me edit it. So if you want to use the Q&A tab, that should be available for you as well.
Okay, thank you very much, Claire. While Chelsea is switching that over, okay. So hello, my name is Denise Parr, and I am from MDHHS, the Infection Prevention Resource and Assessment Team unit. And I had the opportunity to attend the CDC Making Dialysis Safer for Patients Coalition June workshop. And this was a collaboration with the Association for State and Territorial Health Officials. And through this experience, I learned that many outpatient dialysis facility staff were unsure of why their facilities were receiving calls from people like myself at the State Health Department inquiring about conducting an ICAR in their dialysis facility. And so Chelsea Ludington, my infection preventionist team lead, and I hope that today we can clarify the why and the how your dialysis facility can collaborate with MDHHS's Dialysis Infection Prevention Support Program. Next slide, please. So our objectives today are to see why should a dialysis facility collaborate with MDHHS IPRAT? What is an ICAR? The consultation process from start to finish. So onboarding, site visit to facility feedback, and then what happens next. Next slide, please. MDHHS's HAI reduction program could not occur without the collaborative efforts of our team. IPRAT uses a blend of infection preventionists, nurse consultants, and an epidemiologist in our free non-regulatory consultative program for Michigan dialysis facilities. Next slide, please. To ensure IPRAT is taking a comprehensive approach in our dialysis program, we collaborate with internal and external partners. So we have a sister unit called the Surveillance for Healthcare Associated and Resistant Pathogens, or SHARP unit. And We collaborate with them to ensure that all facilities in Michigan are supported for antimicrobial resistant, multi-drug resistant organisms. So together we can help dialysis facilities in mitigating your risk for antimicrobial resistant MDROs such as Candida auris. We also are an active participant in the CDC Making Dialysis Safer Coalition. And we love to collaborate with Midwest Kidney Network. And we are continuously brainstorming with them on ways that we can collaborate to bring you enhanced support without duplications. And then finally, we do work with licensing and regulatory affairs. And how we can do this to not have you be nervous is if we see something or if we have a question and it has a regulatory component to it, what we do is we reach out to our licensing and regulatory affair counterparts, and we ask the question on behalf of IPRAT, and then we take their answer back and then disseminate it back to the facility if the facility is asking and things like that. So there's, we're not sharing your facility name with Lara or anything like that. So don't feel like you're going to be thrown under the bus. We are always looking for opportunities to learn to ensure that we are giving the best evidence-based practices. And so we can be that middle person to where we can take that question anonymously over to Lara and then bring that question, the answer back to you. And you can do that through our inbox. Next, please. So our healthcare associated infection reduction program, or HAI goal, is to provide infection prevention support and services to dialysis facilities within Michigan in order to ensure best practices are followed in order to provide safe patient care and reduce HAIs. And so through this program, what we're hoping to do is to create a symbiotic relationship where we work together in striving for zero healthcare associated infections. This goal is consistent across all of our service lines. So if you are working where you're having some CLABSIs or central line bloodstream infections, and another facility is involved, like let's say like an acute care facility and things like that, we actually have a team that works on CLABSI reduction as well. So we can go in and do a two-pronged approach to where we come into your dialysis facility, we do an ICAR with you, and then we also go into the hospital and we do an CLABSI ICAR with them and see if we can together help reduce that infection rate in your community. Next slide, please. So where does our data come from? Thank you to the NHSN and all of you as dialysis facilities for allowing us to have access to your NHSN information. And so what we do is we pull down that patient safety monthly reporting plan, we look at your BSI events, and then we look at your annual survey. And through that, we're looking at different pieces that maybe can pop out in a risk matrix that could prioritize you for outreach due to a risk factor. So, maybe we see that for some odd reason, due to supply chain, things like that, you're having to now reuse dialyzers, or maybe you have marked on your patient safety component that you have a new IP and they would like more information, things like that. Or we see that your community has a higher rate of central lines versus having fistulas and grafts, things like that. So we can take this data, we pull it together, and then we do our data to outreach calls to where we hope that we can start a relationship with your facility. Next slide, please. So why collaborate with us? Our hope is when you receive a call from MDHHS IPRAT, you will see this as an opportunity to have a fresh set of eyes to evaluate your infection prevention program and practices. Our team has access to the latest evidence-based practice guidance from the Association for the Advancement of Medical Instrumentation, or AMI, American Nephrology Nursing Association, or ANNA, the Association for Professionals Infection Control and Epidemiology, APIC, and the Centers for Disease Control and Prevention, Making Dialysis Safer Coalition. We strive for our site visits to be a supportive educational opportunity with flexible scheduling. However, we do strive to time our site visits so we can observe as many infection prevention practices as possible, so that way we can provide you with a detailed report discussing the items that are being performed well and those that may need improvement. So if you have an infection prevention question, but don't have time to research it, please consider using our inbox. We have a team that is there that can research the answer. We provide it back to you, including the resource hyperlink, so you can see exactly where we found the answer. Next slide, please. An infection control assessment and response tool, or ICAR, is a great way to assess where additional efforts may need to be resourced to enhance your infection prevention program. Our team took the CDC ICAR and enhanced it. We then utilized the latest evidence-based practice guidance from the CDC Making Dialysis Safer checklists. And then we also overlaid from the CMS surveying tool, all the different spots where they talk about hand hygiene and glove changes. And then we also have on that the AAMI standards and APIC guidance. So it's a comprehensive, all-encompassing tool, and it's flexible. So that way we can observe your workflow in an unintrusive manner. So each of our sections are broken into tabs. So if we watch an initiation, and then we see that as soon as that's done, someone else is being disconnected, we can flip in our iCart and go right to that section and actually audit the disconnection without having to scroll through a bunch of different questions, things like that. So we can stay out of the way, we can stay kind of in the fringe, but yet there to observe, answer questions, and hopefully be able to help provide guidance and assistance to the facility. And now I'm going to pass it over to Chelsea.
Thank you, Denise. Hi, everyone. My name is Chelsea Whittington, and as Denise said, I am the Infection Preventionist Team Lead with IPRAT. And I'm going to continue on with our process. So after you have gotten some sort of outreach from our team and decide that you would like to have a site visit, we would work with you to be able to schedule that. And the process for scheduling a site visit involves an onboarding call where we can become more familiar with your facility and the types of care you provide. So during that call, we would discuss demographics, policies, and any items that you would like to focus on, such as those items that you would really love to conduct an IP audit on, but just haven't had the opportunity to do so yet. The average site visit with our dialysis visits has been about 5 hours, but this can definitely be adjusted to ensure we meet your facility's needs. And then at the end of that onboarding call, we will set the date and time for your site visit. And again, we are here to support you, so you can tell us the date and time, and we'll be able to work with you and make sure that it works best for you all. Over this slide, we'll talk about the program infrastructure, and during the onboarding call, we will ask some questions to provide us with some background information, such as your facility scope, reporting, and infection prevention program infrastructure. As subject matter experts in infection prevention program development and management, our team has a deep understanding of the foundational components that should be in place to support a comprehensive and robust infection prevention program. And along with assessing your program's risk assessment, plan, evaluation, and surveillance systems, we also review education and auditing programs for things like hand hygiene, personal protective equipment, water quality, and cleaning and disinfection. And the other piece of our service that we like to do before we go on site is having you send us any policies and procedures you'd like us to review, and we can do so prior to coming on site. So then that way we can provide you any feedback and then have a better understanding of what your staff has been educated on while we're at the facility and seeing if they are in compliance with your policies. So the first part, we will send a site visit agenda after the onboarding call to confirm our site visit date. And then it also provides you an outline of our site visits objectives. So it's broken down into several different parts that I will go through next. And the first is that we like to, if it wasn't done during the onboarding call, we like to review your facility's policies and procedures. And as I said, it can be comprehensive on whatever you would like us to look at, including things like surveillance, hand hygiene, cleaning and disinfection, or occupational health. After this initial meeting, we end up doing a tour of your facility. And so you can think of it kind of like our environmental care rounds. And so it's looking at different areas, such as your dialysis treatment area, clean supply storage, soil utility with medical waste storage, your isolation room, and any other areas you would like us to evaluate. The other part of this within the second bullet here is that this would be when you're observing your staff and then the treatments that are occurring. So some of the things we really like to see if we get there early enough in the day, the setup of the machines, and then regardless of when we're there, seeing the initiation of treatment, watching for moments of hand hygiene, proper PPE use, and standard precautions. And we also want to see the disconnection after treatment, as well as cleaning and disinfection of that machine. Then finally, as we wrap up the site visit, we'll all come together again for a debriefing session. So this will be used to discuss high level or urgent findings, answer any questions you may have, and provide the next steps. So for the next steps, IPRAT typically ends up having about a 7-day business window for getting you any of the deliverables that we will be sending. And if additional deliverables are needed or information or resources, we can also send that as well. So now I want to talk about what you will be getting after we've been on site with you. And there's 2 different pieces. Actually, I'm getting ahead of myself. I do want to talk about the iCar really quickly. Just so you all know what we're using to be able to guide us through that site visit. And so the iCar is the infection control assessment and response tool. Sorry, this is skipping ahead of me before I'm clicking. So, but with this, you'll see at the bottom of the screen that the iCar is broken into tabs like Denise mentioned earlier. And so this helps us be flexible in what we're actually observing. And there's several different tabs that we can click through. And so things like machine setup, medication prep and administration, the initiation and discontinuation of whatever the patient may have. So fistula, graft, and then the central venous catheter. We also have catheter site care, peritoneal dialysis connection and disconnection, station disinfection after treatment, general cleaning and disinfection of the facility, waste disposal, and transmission-based precaution rooms. So now we'll go into deliverables. And there's 2 main ones that we end up sending. The first is the high-level summary, and you can think of this as a bite-sized version of the assessment report. And with this report, it can be shared with dialysis facilities leadership team and includes items that are high risk, require systematic change, or require significant financial resources for improvement. And within the high-level summary, we do include a Pareto chart that helps program stakeholders to determine priorities for performance improvement planning. And this chart is really cool because it does help prioritize what you should be working on first to make the biggest impact for your overall goal. And the second deliverable we have is the assessment report. And with this report, it's basically a translation of our iCard, just in a easier to read format. And it includes all of our different recommendations and resources that we have here. And so then I'll help you be able to review and implement it into your quality assurance program. So this slide just shows a quick snip of what the assessment report looks like, and this is within the hand hygiene section. And as you would scroll through the report, you'll see the different areas that may be meeting recommendations or not meeting recommendations. On this here, you can see that the facility did not meet current recommendations or guidelines. And if that occurs, we'll provide the observations on why it does not meet the iCar point there. So for example, hand hygiene policies promote the preferential use of alcohol-based hand rub over soap and water in most clinical situations. And for this example, the hand hygiene policy does not include that statement. So then we'll provide the recommendation on how to actually fix that and align with what is recommended throughout the guidelines and other regulatory pieces. And then the last piece within it will be the references. So where are we actually getting those recommendations from? It'll be included right there for you to link to be able to talk about and show and research a little bit more if you want to go a little bit farther in depth than what's here within the assessment report. And then I wanted to share what's next. So what happens after all of those pieces come into play? And I do hope that this presentation created an opportunity for you to better understand how IPRAT would like to collaborate with you. Again, Denise said this, but I really want to make it known that we are a free non-regulatory infection prevention consultation service here to support you. So look at your calendar, discuss with your leadership team the educational opportunity for your facility to collaborate with IPRAT, or please feel free to reach out to us after this call. And we can support you either through a site visit or any questions you may have if you want to send them to our inbox. And the link that I have here and something that Denise will be dropping into the chat is the Enhancing Dialysis Safety Voices from the Making Dialysis Safer Coalition. And this is what Denise referred to earlier today, where in June of 2023, the Making Dialysis Safer for Patients Coalition convened representatives from public health departments in dialysis settings to talk about infection prevention and patient safety in dialysis. So this will talk a little bit more about our program, as well as some of the other programs that are found throughout the country. I believe someone from Nebraska spoke and someone from LA. So it was just a really interesting thing to be able to listen to and get more information on what's occurring out there. And here's our contact information. So again, our email that we can also drop into the chat. Oh, Denise already did, I see. Beautiful. And then we have our phone number, as well as if you want to learn more information about our team, we have a website. So thank you all so much.
Thank you, Denise and Chelsea. I wanted to include that kind of a brief high-level overview of what an ICAR or IPRAT visit entails is kind of the last section of that sepsis resource toolkit that I referenced during our presentation, and I just dropped that in the chat, which I did manage to get working. And really encourage people to utilize that resource in your state. So Denise and Chelsea are from Michigan. And like they said, it's this free, fresh set of eyes to, do that audit, that very thorough overview of your facility and help you kind of come up with that implementation plan, that QI process that I had referenced. So we have just a few minutes left in what we had scheduled, but we can always stay on later if there were extra questions or comments or discussions people wanted to have. But does anyone have any questions right away? You can put them in the chat now that it's working, or in the Q&A. And I will launch our last poll here that should pop up now, and you'll see, again, the same question. Our dialysis facility has areas for improvement in infection prevention, if there was any change in your answer. 2, I understand the purpose and process of an ICAR or /IPRAT visit. And 3, if it applies to you, if you're a dialysis facility listening today, if you think this is something that would be able to help evaluate and improve your infection prevention processes that are currently in place at your facility. And one thing I wanted to briefly discuss, I didn't mention it, is that, while we partner and collaborate together as different entities, we do each, what do I want to say, sort of own our own data. And that's something that's kept private. When Chelsea and Denise are out doing visits, they don't call me and say, oh, Claire, we saw this, and this going on. And just like, I don't tell them, oh, this place has a hospitalization rate that could use some work. I reach out to people on a facility level and say, I think there's an opportunity for improvement here. And we kind of help support each other and promote each other's work. But it's not like your data is shared with each other. We do respect that data integrity and keep it private. We'll give it a few more seconds here. And I want to thank everyone for joining us today and participating. I hope that you found some of the information useful today. And if anyone has any questions, you can feel free to jump in now. All right. Well, if there's not anything from anyone in the group, thank you again. And I will get the recording out to everybody. We will also have it on our website, and I'll put my links that are in the chat, and along with Denise and Chelsea's links into that follow-up email. And thank you all. Have a good rest of your day, and good end of the summer heading into fall season for those of you who are excited. Thank you.
Thank you.